Hello, everyone. My name is Emily, and I'm a medical student at The Ohio State University. I'm happy to present, can Fibrin Glue replace drains for abdominal wall reconstruction? Here are our team's disclosures. My mentor, Dr. Benjamin Paulos' disclosures are listed here. There are no other authors that have disclosures at this time. So surgical site infections are an ever-growing problem in our community, and as much as we do to minimize it, it still accounts for 20% of all hospital-acquired infections. As you know, SSIs have a cost, a morbidity and mortality, and a length of stay burden for patients and for hospitals. And of the 400,000 ventral hernias performed each year in the US, the incidence of SSI is almost 5%. That's an increase in hospital stay by over 9 days, with over $20,000 in additional hospital expenditures. The traditional approach to minimize this by abdominal surgeons is by using a JP drain, with the thought that it acts as an early indicator for bowel injury, fluid collection, and potential signs of infection. But it's generally not patient-friendly. It's cumbersome to have a bulky appendage attached to the body, and patients don't really like it. So other alternatives have been explored, one of which is Fibrin Glue. Fibrin Glue is a combination of fibrinogen, bovine thrombin, and calcium chloride, and its job is to mimic the body's biologic coagulation in order to seal off tissues and help with hemostasis. It has been shown to have less traumatic fixation and obliterates dead space, and it has been shown in the literature to have less chronic and acute post-surgical pain compared to staples or tacks. There is less in the literature to describe how Fibrin Glue affects infection rates, and so we tried to fill this void by studying whether mid-weight polypropylene mesh with fibrin is associated with a significant difference in SSI compared to that of traditional drains in ventral hernias. We conducted a retrospective analysis using ACH-QC data and divided our patients into two groups. The first was the Fibrin Glue group, which were electroventral hernias in the retromuscular space that received Fibrin Glue only without a drain, and a retromuscular drain group, which received a drain only with no Fibrin Glue. Our primary outcome was surgical site infection at 30 days, with a secondary outcome of surgical site infection requiring procedural intervention. Some of our initial data, our patient population was mostly white females over the age of 60. They were ASA class 2 and had a BMI of about 32. The hernia width for the majority of our population was between 4 and 10 centimeters for both groups. And as you can see here, of the patients who spent less time in the OR, under 180 minutes, a higher percentage of patients within that group received Fibrin Glue, and of the patients who spent more time in the OR, more of those patients received drains. So we conducted a propensity score match in order to better match both of our groups using the following 8 covariates: hernia width, ASA, history abdominal SSI, BMI, wound status, sex, diabetes, and whether they were a current smoker. And as you can see here, we were able to match both groups fairly well, and we cut the differences in about half. So these are our results before and after matching patients. Before we matched patients, there was a significantly higher rate of postoperative complications in the drain group compared to the Fibrin Glue group, but there were no differences in surgical site infection or surgical site infections requiring procedural intervention. After matching, there were no statistically significant differences in SSI, SSOPI, or post-op complications. There were also no significant differences found in wound cellulitis, types of drainage, or presence of seromas in either group. This study should be interpreted among these limitations. We did have a smaller sample size for our Fibrin Glue group. There were 144 participants. And given that Fibrin Glue is a relatively newer technique, it was unsurprising to us that our sample size was smaller. We did use a propensity score match for this reason in order to better compare both groups. And we used covariates that we felt would cover the most confounding variables. And there may have been factors outside of this that we did not account for. And we used one type of mesh in a single location. But outside of that, we feel that our results are very promising. Fibrin Glue was shown to have similar rates of SSI and SSOPI compared to drains, and we found similar hernia recurrence and reoperation rates between Fibrin Glue and drain patients, with the added benefit of not having a bulky appendage for patients attached to the body. For future directions of this study, we'd really like to identify whether Fibrin Glue and drains impact infection rates at a different level with minimally invasive approaches like laparoscopic, and whether Fibrin Glue works better or worse or the same with different types of mesh and in different types of locations. And I'll take any questions. So I think the literature is a little bit unclear as to whether drains do in fact decrease the risk. I guess you're right, we did go under the assumption that drains do decrease the risk compared to nothing at all. Our question was primarily comparing Fibrin Glue to drains, and we found that there were similar infection rates to both. So seromas specifically, I know we did for non-infected and infected seromas, we did not find any differences in between two. But I guess presence of seromas we didn't specifically account for. We just said if they had a seroma, was it infected or not? But that would be a great one to look at. Thank you. So there were a subset of patients that had both. We chose to exclude those because we wanted to primarily compare Fibrin Glue alone to drains alone, but that is certainly something in future studies we want to look at. I'm sorry, can you repeat that? That's not currently captured in our database. Thank you.